Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy with my good friend and colleague, Alan Francis.
Good morning, Marvin.
Good morning, Alan, and myself, Marvin Goldfried. So one of our listeners / watchers sent us an email and said, gee, it would be nice if we spoke about humor in therapy. And I thought, interesting. But Alan, you're the one that jumped on this and said, oh, that's wonderful. So I'm going to let you do the talking.
I think it's a great topic. I think that a lot of the really simple things in therapy are not discussed enough, and this is one of them. It's come up from time to time in the literature, and I've been mortified reading people recommending that there should be no humor in therapy. There's a school
okay.
Saying that
well, that's different from saying humor is important in therapy.
Well, I think that may be the balance we'll be discussing today, the golden mean of where is humor absolutely necessary and appropriate, where is it inappropriate. And I think that you're an expert in this topic. Marvin claimed he didn't know anything about this, but Marvin's one of the funniest people I've ever met. And it will be interesting as we go along to see how Marvin has managed to express and at sometimes contain his sense of humor, because it's usually so infectious.
Well, I appreciate the compliment, but you wanted to do this topic. I was lukewarm about it, so don't pass it on to me, my friend. You know, you're going to one that's going to do the talking. You're going to one that's going to have to convince me that there's something to say about the therapeutic value of humor. I mean, that's how I interpret it, at least.
Yeah, I don't think that's hard. I think that why do humans, let's go back to basics. Why is humor so important to human beings? Why is being funny so crucial an aspect of human behavior? And Darwin actually had a great answer for this. He wrote a wonderful book in 1872. He had saved up his notes from The Origin of Species, and 13 years later published two books that described how humans fit into the evolutionary picture. And in one of those books described sexual selection, and humor is part of sexual selection. That those people who were funny, who were entertaining, were more likely to survive. That it's not an accident that we're funny. That would be an aspect not of natural selection. There's nothing about natural selection that would say human beings should be funny, but there's a lot to say about sexual selection and its interest in having and survival value in funny.
What do you mean by sexual selection?
Oh, this is a long other story, but and you'll recognize it as I get into it. Darwin's initial evolution book, The Origin of Species, was published in 1859, although he had done the original, he had the ideas for it 20 years before, and he was just building up the case before publishing it. And natural selection was obviously the idea that those creatures that were producing more offspring those genes, but those features would survive over the course of evolution. Mm-hmm. And it would be a survival value. The natural selection would be based on who could survive into reproductive age and produce the most offspring, who would also survive into reproductive age, who would produce the most offspring.
Mhm.
But he realized that this wasn't the total explanation for how we acquire the traits we acquire, that sexual selection would also be important, that choosing a mate would influence reproductive capacity, and that various aspects of human psychology, it's a very interesting point, that many aspects of human psychology would be based not necessarily on their impact on natural selection, but rather their impact on sexual selection, how mates were chosen. And sense of humor would be one of them. The people who were funniest. Marvin, you would attract women, not because you're the handsomest guy in the room, but because you're the funniest. If you get
I haven't necessarily found that the case, but there's an element of truth that resonates. And that is, my wife said that she decided to marry me because I made her laugh.
There you go.
And I'm reading Paul Newman's autobiography. And then I came across a section where his wife, Joan Woodward, said, I married Paul because he made me laugh.
So you're living proof of Darwin's theory.
Well, it's what is it, an N of 2? He's much more better looking than I am.
It's an N of all of humanity. And I guess that's the point, that we are a species that laughs and that finds humor in things, and that our genetic makeup, we don't teach people to be funny. It may be partly it will be partly influenced by nurture, but a lot of it is an inbuilt capacity. That's something that you don't have to work hard being funny. You don't really study to be funny. It's part of the human capacity. It's an important way of dealing with life's adversity. The people who can see the humor in things are able to deal with painful experiences. Go ahead. I see an expression, Marvin. What is that expression?
Yeah, okay. I'm thinking about how these clowns that go to hospitals to cheer up kids, or put on this red nose and make them laugh, and I could see the value in that. Okay, and yes,
I'm not talking about that.
Okay,
I'm talking about day to day an attitude of being able to distance yourself from situations enough to have an ironic view of painful experience, to see the humor in the tragedies of life. Charlie Chaplin had a great quote that life is a tragedy in close up and a comedy when you take the long view. A comedy.
So how does this fit into therapy?
Okay, well, that's the point. That a life without humor would be excruciating. Can you imagine if you had gone through your whole life never finding anything funny? It would be absolutely excruciating. And I think a therapy without humor is part of the warmth. It's part of the oil that lubricates human relationships. That a therapy that would be completely somber and serious every single moment would be lacking in the essence of life. And I think that we have to discuss when humor can be harmful to a therapy, when it can inhibit a therapy, and the reasons why some people think humor can be dangerous in therapy. But we have to recognize that at its core, therapy is a human relationship. And at its core, every human relationship should have the warmth of humor as part of it.
Okay. My feeling is, Alan, we're circling around the issue that I'm skeptical about. The issue is, where does it fit in therapy? Would you refer somebody to me? Oh, yeah, I've got a good therapist for you, Marv Goldfried. He's very funny. You wouldn't say that.
But I would refer him to you partly because you are very funny. And your being very funny is part of the spice of what would make you a great therapist.
Well, you still haven't convinced me.
Would I refer someone to a therapist who had no sense of humor? No, because I would see that therapist as being dried out, cold, unable to bring life into a treatment. I see humor as part of life. And I think every therapy has to have the warmth and life of human relationship at its core.
Okay, so let me translate it in my head. I mean, specifically addressing the question of humor in therapy. You're saying something to the effect that if the therapist has a sense of humor, that says something about her or him that works toward the therapy alliance. How?
You tell me.
No, you tell me. That's why.
Well, I think I have, Marvin. I think I have told you that
Somebody comes in and is depressed because they lost their job.
Yeah.
Tell them a joke about somebody who's unemployed.
You're not going to be making jokes in the first minute with someone who's depressed.
Okay.
And this goes to the two reasons. The dour people who say we shouldn't use humor in therapy have two rationales for eliminating it. One is that therapy is serious business. Life is filled with tragedy. Our patients are coming to us at their worst moments. That their worst moments, they're not going to be prepared to see the world in a different way. And that a therapist who's too jokey, especially as the relationship is first forming, will give the patient to feel that their problems aren't being taken seriously, that the therapist couldn't possibly understand them. They're not feeling that they can respond to a joke. How can you possibly be happy and jokey when I'm so miserable? Would maybe feel that the therapist is mocking them.
Mm-hmm.
And so that these are the reasons offered for not introducing humor. And it's obvious that you're not going to be laughing and joking with someone who's just lost a child or is in the midst of a serious.
Okay, let me be very focal. And you know that I do have a behavioristic background. So let me ask, what's the function of humor in therapy? What does it do?
Well, you're better at this than I am, Marvin. You should be telling, you're the funniest person in the world. You treated 1,000 patients. What has it, when were you funny? When were you able to, in a gentle way, introduce your sense of humor with patients? I'm sure you haven't gone all these years.
Yes.
Never ever sharing a joke with a patient.
I'll give you an example and then tell me why this might have been therapeutic. Because that's the function. You know, why does it work? Worked with a depressed patient and he was making very good progress. And then came in and a session and he was talking about how well he was doing and he was kind of like smiling. And I said, hey, you're not supposed to smile. You're depressed. And he chuckled. So
there you go.
Okay, you like that, huh?
I like that. Yeah.
Why?
Why'd you say it?
Why do you like it?
No, why did you say it?
Why did I say it? Well,
I want to be Socrates in this relationship.
Okay.
I'm the midwife to your ideas.
Okay. First of all, I wanted to get the person to step back and observe the fact that he was doing something that was a representative of change in therapy. So anytime I see somebody doing something or saying something that represents a change, I use that as a therapeutic marker to process that.
But why did you do it in a funny way? Why didn't you just say it in a very sort of serious?
Well, because that's who I am.
Yeah, but why you like that, Marvin? Why you like that?
I don't know. I mean,
it's intuitive. It's not something they taught you in behavior therapy school.
Oh, come on. You know, it's like, funny thing happened to me on the way to the therapy session today. I need to know the function. So here's okay.
Why is it fun for us to be teasing back and forth? Why is it that the people who follow this podcast, when they comment on they like it, it's because of the back and forth humor? Why is that?
Okay. Why do they? But then is this therapeutic to them?
Sure, of course it is.
Well, okay. Yes. If you laugh, it feels good. People pay.
If you laugh, it feels good.
Yeah.
That's a good start.
So, but that's not why I said you're not supposed to laugh if you're depressed. Not just as a palliative kind of thing. It was to stop the flow of conversation and have the person self-observe and then talk about what was going on.
But that's precisely my point. Why was it so much more effective to do it in a humorous way rather than to do it in a ponderous?
I don't know if it was more effective. I mean, sometimes I say things in a funny way and it just bombs.
Exactly right. Now, when does it bomb and when does it work?
It bombed the other day. This was a person who I've been working with to get them to accept the fact that they are a sexual minority. And this is an elderly person and confessed to me that they were attracted to the same-sex aide that had come in to assist. And we had been working on acceptance of sexual orientation. And my reaction, so I thought that the person was partway there to self-acceptance. So my comment was, oh, that's wonderful. And no extra charge for you to be attracted, huh? And I thought it was funny, and it kind of just fell dead and flat.
Okay, I think this is great. I think that you're a great subject for this kind of conversation.
Yeah.
What's the difference between the two things? To me, the difference is when it works, it's something shared. And there's something special about sharing a humorous view to something. It brings the two of you really close together in a way that could never be as close if you just said it in a didactic manner. That it's pithy, it's intense. We share the joke. When you share a joke, you're sharing something. It's making the therapeutic relationship. We have a little secret. We can both get this.
Yeah.
When it bombs, it's like, we're on different wavelengths.
Uh-huh.
You don't really get me.
So it's almost as if you're saying, but you're not quite saying it, or it's almost as if you're meaning that.
I want you to say it, Marvin. I'm Socrates, and I'm just a midwife. You're giving birth to these ideas.
So Socrates,
That's a joke.
Socrates, my friend Socrates, what I hear you saying is that the sharing of something through humor is an intricate part of the therapy bond between the therapist and the patient. Just like people who know each other for a while can say something very cryptic and they understand, even though other people may not.
Yep. You said it better than I could. And that's a kind of magic moment.
It's a connection.
Yeah.
But the content is important too.
Of course. But the content wouldn't have the same meaning, emotional meaning, wouldn't lead to the same corrective emotional experience if it were given in a bland, manualized, stereotypical kind of way. Boring. If it's boring, it's not going to work.
So, Dr. Socrates, I have a question for you. Yes.
Mr. Socrates.
What did you say?
Mr. Socrates.
Mr. Socrates. Okay. What was his first name?
He only had one name.
They only had one name. They were very poor back then. Anyway, no, I forgot what the question was. Not wait, it'll come back to me. This is getting totally ridiculous. There's too much humor in this podcast, I think.
Well, but it's and this is one of my favorite ones because it's not programmed.
Yeah.
It's not based on textbook knowledge. It's something that people share.
Okay, I got the question. It's come back. And so I have a supervisee. Should I say to them, you got to be a little more funny during your sessions? Yes or no?
More, I would say, and you have to be human.
Well, that's tricky because humans have all kinds of emotions. You have to be human but therapeutic.
And let's be honest about this. I'm not saying that humor by itself is enough. I'm not saying that humor always works. I'm certainly not saying it can't be detrimental. So it can be absolutely the worst thing you can do with someone who's so miserable that they're going to regard you as not understanding them or making fun of them.
Yeah.
There are moments where trying to be jokey is the worst possible thing you could do.
No, I understand that. You're saying when you use humor and when you don't. But what would you recommend to all supervisees that they should involve more humor in their interventions?
I think people who are congenitally funny should probably do less. People who are very inhibited should probably do more. And there should be a golden mean that you can't teach because it's part of the human relationships. And that part of being a therapist is something I don't think you can really teach very well.
Well, I would recommend exactly the opposite. You said people who are congenitally funny should do less, and people who are not funny should do more.
People who are inhibited and feel, I have to be very serious every session.
Oh, okay.
Never let myself go.
But if the person's not capable, okay.
If the person's not capable of being funny, they shouldn't be a therapist. How about that?
Well, I don't know.
Because I would say a person who's not capable of being funny probably should go into a tech industry or maybe be a pathologist.
I really remember very few, if any, examples of my observing expert therapists doing therapy where they were funny.
Oh, that's not my experience at all. Actually, I have the opposite experience. Ackerman was hilarious. Searles was hilarious. Most of the people I worked with could be funny. And the ones I didn't like were the ones that were too, supervisors I didn't like were the ones that were so solemn.
I think, was it Mnuchin who said to the mother of this young adult during a family session, "You're a wonderful mother. You're a caring mother. You're a loving mother for a 6-year-old."
So there you go.
So what does it do? Let's analyze it. And I know.
Well, you're just contradicting yourself. You said,
okay. Well, no, I'm growing. I'm changing. Okay. It's what you do is you are saying something that makes the patient work and think, rather than telling them the final line. And in humor, something is funny because you say it, and then a person, it's kind of like unexpected, and then they have to think about what's going on. Like, okay, here's one.
That's a great thought, by the way.
I sometimes tell this to patients. How often have you thought you would just explode and fall on the floor when you gave a talk? Oh, beforehand. How often have you done that? All the time. How many times? Hundreds and hundreds. Okay. How many times have you fallen on the floor during a talk? And there's a pause. And the pause is they're now doing self-therapy.
Okay.
So one of the functions, perhaps, is that it gets the person to work rather than feeding it to them.
And a step before that, it gets the person's attention.
Yes.
So one of the key things in therapy is you have these, say, 45 minutes, and not every one of those 45 minutes is equal to every other one of those 45 minutes. At times you have the patient's attention and crisp and wonderful things can happen. And a lot of the time it's just talk. Yeah. And a well-placed, humorous observation gets the patient's attention. It changes the pace of things. Mm-hmm. And it gives distance. You both have some distance from what's happening.
Yes, there's a self-observation, and there could be an acceptance. Right. Or a matching up of the example of matching up of the reality with the expectation, the fearful expectation. But the point I want to go back to is, I think it's very important that this is the way you started today's podcast, saying you think I'm funny.
I don't think you're funny, Marvin. You are funny.
All right, but whatever. But you associated with humor with me. So for me to be a person in the session, for me to be authentic, if you want to use a Rogerian term, I need to be me with obvious boundaries. And exactly. if part of me is always making or trying to make funny jokes. It doesn't always succeed. Our wife will attest
Part of
to
you
that.
says, I can never be myself. I can never make an observation in a humorous way as opposed to a serious way. Then you're not being yourself, and you're not giving the patient the benefit of what may be one of the very best parts of yourself.
Right. So it's being yourself rather than being human, because some people are not that funny. I mean, you're funny.
I'm a little bit funny. You're a lot funny. I'm a little funny.
But you got a good laugh. So I think that's why we make a very good team.
And also, I think as a corollary to this, sessions are often going to be very painful, but there are times when sessions should be fun. And for someone who doesn't have much fun in life, especially the treatments that are more supportive, where you're not striving for change so much, the idea of being able to have fun in a session is a positive thing. It helps to reverse demoralization.
Yeah. No, it's nice when the surgeon says beforehand, before you go into surgery, I've done this a million times. I could do it in my sleep, but I promise you I won't.
Right.
And I assure you everything's going to be okay. There's the demoralization. There's the assurance. He or she would not joke unless there was a sense of confidence. So it can diffuse.
The therapies, when they work well, bring up for the patient, some of the more painful experiences they've had, the emotions they least like, the memories that they would rather not have. And that's part of life, that's part of therapy. But it should also be leavened with things that they're happy about, things that they're proud of, things that they can look back with pleasure. And a therapist, I think, should be sharing a patient's life, not just in its worst moments, but also in its happiest.
Okay. You convinced me.
Well, I don't think I convinced you. I think if you look back at the thousands of treatments you've done, my guess is that you've always been comfortable using humor.
Yeah.
It's not something you thought of as a tool in the therapy, as a specific tool, even though you've done it unconsciously.
Yeah. I think it's grown over the years. When I first started doing therapy, it was horrible. That's a whole other story. I never would have gone to me if I needed some help.
Because of what?
What?
Why?
Because I knew nothing about human functioning, and the state of the art was really crappy, and there were no clear guidelines, and the faculty teaching the courses were not very helpful, and the supervisors that I had were not very helpful. So, we're talking back in the 50s. It was really pretty bleak. Things have gotten much better in many, many ways. So, but that's a whole...
I had a completely different experience. Mine was in the 60s. And the supervisors that I really liked and in a way loved were the ones who said, we're going to teach you stuff, but basically what helps most is the relationship with the patient.
Yeah.
And you already know a lot about doing that, otherwise you wouldn't be in our program. And so mostly you're going to be yourself, but we're going to refine that. But I never felt at the beginning like there was this vast amount of stuff that I didn't know that I had to learn. I felt at the beginning that if I could just be myself, that would in itself be helpful, and hopefully I'd get better and better at it.
I can't remember a teacher or a supervisor who ever said that to me. So you were very, very fortunate. And maybe it was your training that you got, but it could also, have been, 10 years later, things have got better. Okay, well,
let me just say one thing. The supervisors I liked the most came from the interpersonal school.
Yeah.
There was Harry Stack Sullivan type supervisors at Columbia at the time.
Yeah.
And also Ackerman, who was a family therapist, where relationships would obviously be the most important.
Yeah.
So I could
see that. I could see that. Okay.
Okay.
So I'm going to say something. Hopefully, it's not going to be funny, but hopefully it'll make you feel good.
Okay.
Ready?
Yeah.
Alan, you were right. Talk to you next week.
I get that so little in my life.
I know, that's why I'm saying it.
I usually get, Alan, you were wrong. Thank you, Marvin, for reassuring.
Stay safe. See you next week.